talents, Dr. Rafik Elias, discussing the diagnosing neurovascular compression with AI, our institutional experience.
Thank you, Doctor. Good afternoon, everyone. My name is Rafik Elias. I'm a diagnostic and intervention radiology resident at Ain Shams University Hospitals, and I'll be sharing with you our work using AI in diagnosing neurovascular compression in cases of trigeminal neuralgia. Before we begin, I would like to acknowledge the tremendous support of our mentor and team leader, Professor Dr. Tugan. I would also like to thank Dr. Rana Mohsen, our engineer Ahmad Zalouk, as well as my fellow resident and friend Mohammed Zalouk. Here's an overview of today's work. We'll begin with showing you how AI has been reshaping neuroradiology lately. Then we'll be moving on to trigeminal neuralgia, how it presents clinically, its classification and diagnosis. Then we'll jump to the imaging protocols, and finally I will walk you through our own work with the AI models, and we'll be sharing our results so far. So this is a short introduction. Over the past few years, AI has made major progress in neuroradiology, transforming the field from an image interpretation field into a data-driven field that integrates advanced technology into clinical care. In the early ages of AI in medical imaging, most systems were built using handcrafted algorithms. This meant that progress depended heavily on human input, making these systems rigid and relatively narrow in scope. The actual revolution began with the rise of deep learning, and since then, AI systems have become far better at automatically detecting, classifying, as well as measuring findings on a variety of imaging studies. This is our first example. So obviously AI has already been applied successfully in neuroradiology in detecting, in this case, microbleeds on susceptibility-weighted imaging, as shown in this paper published in 2015. And more recently, we had advancements like VisAI, which received FDA clearance for automatically detecting intracerebral hemorrhages in CT scans. So this shows AI's growing clinical role in the past few years. So we've just seen how AI is enhancing how we process images, detect subtle findings, as well as predict outcomes. But beyond the pixel and the algorithms, our focus must always return to the case itself. So allow me to leave AI for a bit and focus on trigeminal neuralgia. Trigeminal neuralgia is recognized by repeated attacks of sharp electric shock-like sensations localized to the sensory supply areas of the trigeminal nerve. These episodes are usually very severe, and unlike most chronic syndromes, the attacks are extremely brief, so just from seconds to at most a couple of minutes. Everyday activities can trigger these attacks, like simply chewing or brushing teeth, and the pain always affects one side of the face. And actually, if it's bilateral, we usually think about another diagnosis. There are three recognized genres of TN. There's classical TN, secondary TN, and idiopathic TN. And the classical genre accounts for approximately 85% of all the cases. It's usually caused by compression of the nerve by a vessel, what is known as neurovascular compression syndrome. The superior cerebellar artery is responsible for most cases, about 60 to 90%, followed by the anterior inferior cerebellar artery, and finally the basilar artery. In most cases, the compression often occurs at what's called the root entry zone, which is the first segment of the nerve when it leaves the brainstem and moves anteriorly through the prepontine cistern. Secondary trigeminal neuralgia, The main culprits here include posterior fossa tumors, such as vestibular schwannomas, meningiomas, and cysts, demyelinating diseases like multiple sclerosis, for example, and vascular lesions, such as aneurysms or AVMs. And of course, the idiopathic genre is essentially a diagnosis of exclusion. So we use this naming when there's a picture of trigeminal neuralgia clinically, but the imaging does not reveal compression or any other secondary pathology. The diagnosis of trigeminal neuralgia is primarily clinical, based on the patient's history. A trigeminal neuralgia brain MRI includes many sequences, with each sequence aiming for a specific aspect of the pathology. So we have, most importantly, of course, the 3D heavy T2 sequences like DRIVE or Fiesta, which allow us to assess the whole nerve, the whole course of the trigeminal nerve. We also have the contrast-enhanced T1 sequences for tumors and plaques, FLAIR for demyelination, and MRA for vascular anatomy. And recently, DTI has been explored for trigeminal nerve evaluation, but unfortunately, the small size of the nerve makes this challenging, and it's still not routine in our clinical practice. Now, let me walk you through our own work. So we started by gathering our data, which in this particular project consisted of 3D drive, axial and coronal images of clinically known cases of classical trigeminal neuralgia, as well as age-matched controls. To properly train our A model, we needed to feed it with, let's say, both ends of the spectrum. This means that not only we had to give it clear cases with the neurovascular compression, but also normal controls with no detectable compression. So here we have a few examples of cases with no detectable compression. And here we have a few examples with compression, with the white arrow showing the exact site of contact. To prepare the data, we had to standardize the images by resizing them to the same amount of pixels. And we had to preserve this aspect ratio in all the data we've gathered so far. We then had to scale all the pixel values between 0 and 1. This ensured that the model sees consistent value ranges, which gives better outcomes. We also used data augmentation by randomly adjusting brightness, contrast, and applying vertical and horizontal flips. This slide basically explains how we classified the data during pre-processing. So we had 4 main questions to answer for each image. First, we assessed whether the patients were symptomatic on the right side, the left side, or both, recorded simply as a yes or no. Then we evaluated the degree of neurovascular compression on both the right and the left side. So the contact was graded on a scale from 0 to 3. 0 was no contact at all, 1 was abutting, 2 indenting, and 3 was given when the vessel was totally displacing the course of the nerve. The models used for this project were what's known as CNNs, convolutional neural networks, as well as vision transformers. CNNs are a model that work basically like us radiologists, so they scan the image region by region, searching for any abnormality. We also tested vision transformers, which is a newer technology that analyzes global relationships across the entire image, rather than scanning the image region by region. Our results shows that DenseNet 1-to-1, which is a CNN model, performed best, particularly in identifying the degree of compression on both the right and the left sides. We actually went through 2 main versions of the training, the AI models. The first one included about 270 images, I think, which gave us promising but somewhat limited results. That's the accuracy of about 40% in red. The next iteration, we used more images, of about 530 images, and the model performed significantly better. So this demonstrates how important the data set size and diversity are in AI research. The more representative examples we feed the model, in our cases with neurovascular compression as well as normal controls, the more accurate and clinically useful it becomes. So like we've seen, AI shows promise as a valuable assistant to radiologists, which later on may be particularly helpful in cases of neurovascular compression syndrome that are not straightforward. Thank you.
Thank you, Dr. Rafik. And before closing